the modified posteromedial approach to the posterior tibial plafond. Welcome. In this video, we'll walk through the modified posteromedial approach to the posterior column of the tibia, a technique for complex pilon fractures that exposes the entire back of the distal tibia through a single, elegant plane. This work is not my own. The approach, the anatomy, and the surgical steps you'll see here are based entirely on the article by Assal, Ray, Fasel, and Stern. A modified posteromedial approach, combined with Extensile Anterior for the treatment of complex tibial pilon fractures, published in the Journal of Orthopaedic Trauma in 2014. I'm deeply grateful to the authors for describing and sharing this technique so clearly. Full credit belongs to them, and I'd encourage anyone interested to read the original paper for the complete details. This video is intended purely as an educational summary to make their work more accessible. All illustrations are original, and the source is cited throughout and in the description below. In a complex tibial pilon fracture, the front of the joint is what you see, but the back is what holds everything up. Before you can rebuild the comminuted, impacted anterior surface, you need a stable, correctly lengthed posterior column to rebuild it onto. This is a posterior approach designed to expose that entire column directly. The key observation is simple. On a cross-section of the pilon, an incision placed just medial to the Achilles tendon leads you straight down to the center of the plafond. That single line is what opens the whole back of the tibia. Positioning. The first stage is done with the patient prone. Place a bump of sufficient size under the anterior tibia so the ankle can still move through full flexion and extension during the case. The incision. Begin the incision just proximal to the insertion of the Achilles tendon on the calcaneus, 1 centimeter medial to its border, and carry it proximally for about 12 centimeters. Stay medial to the tendon, never in the midline. This matters. If the wound is slow to heal, a midline incision risks exposing the tendon itself. Through the superficial compartment. Open the superficial fascia to expose the Achilles tendon and the distal fibers of the soleus. Retract the Achilles laterally, taking care to preserve its sheath. Any soleus fibers attached to the deep surface of the tendon are simply carried laterally along with it. The bulk of the tibialis posterior is retracted medially. Now dissect bluntly down to the transverse intermuscular septum. This septum is the floor of the superficial posterior compartment, the sheet that separates it from the deep compartment underneath. Entering the deep compartment. Divide that septum longitudinally in the midline, and you enter the deep posterior compartment. The tendon and muscle belly of the flexor hallucis longus now come into view. Along the medial border of the FHL, look for the tibial nerve. It sits right there, and it must be respected. Open the septum delicately. The nerve can run more obliquely than you expect, and as you move proximally, it lies more centrally. The defining maneuver, FHL off the column, develop the interval between the medial border of the FHL and the tibial nerve, and retract the FHL laterally. This is the heart of the approach, and note that it works through intermuscular planes. It is not an internervous approach. As you retract the FHL further, the entire posterior column reveals itself. The posterior metaphysis, the posterior capsule of the ankle joint, the posterior syndesmosis, and the posterior surface of both the medial and lateral malleoli. Proximally, you can follow this same interval up to about the junction of the middle and distal thirds of the tibia, as far as the fracture requires. Reduce the displaced, shortened posterior fragments under direct vision, with the external fixator supplying traction and alignment. The objective is to recreate the posterior anatomy of the tibia, and above everything, to restore proper length along with axial and rotational alignment. Stabilize the posterior column with a long, small fragment locking T-plate. A 2.7 millimeter reconstruction plate also works. Make the plate long enough for solid bicortical purchase on the intact proximal tibia. Keep the distal screws at the level of the pilon, relatively short so they won't interfere with the anterior reduction and fixation that follows. That brings us to the end of the modified posteromedial approach. I want to be very clear about what you've just watched. The concept, the anatomical rationale, and every operative step shown here belong to Mathieu Assal, Adrien Ray, Jean Fasel, and Richard Stern. Their cadaveric work and clinical series are what made this exposure reproducible for the rest of us. This video is nothing more than a teaching summary of their contribution, a signpost, not a substitute. If this approach is something you may use, please go to the primary source and read it in full. Assal M., Ray A., Fasel JHD, Stern R. A modified posteromedial approach combined with extensile anterior for the treatment of complex tibial pilon fractures, AO OTA 43C. Journal of Orthopaedic Trauma, 2014, Volume 28, Issue 6, pages E138 to E145. The DOI and PubMed link are in the description below. The original article carries detail, nuance, and case material that no 10-minute summary can convey. My sincere thanks to the authors for their contribution to trauma surgery and to the Journal of Orthopaedic Trauma, and thank you for watching. Thanks for watching. Subscribe Orthopedics Trauma in YouTube.